All right, welcome back and thank you so much for staying with us. In case you're just joining us, this is Daybreak. This morning we are talking about the status of healthcare in the country and of course what we were discussing earlier that started this conversation was the burden of cancer in the country and the way forward on how to alleviate the suffering of thousands of Kenyans who have had to suffer and lose their loved ones because of this disease, and talking about the trends we are reading and what they should do to inform our interventions. In studio, we have a panel of three: Honorable Patrick Munene, the Member of Parliament for Chika-Igama-Ng'ombe constituency, who also sits at the Health Committee at the National Assembly as the Vice Chairperson. We have Davji Bhimji, who is the Secretary of the Kenya Medical Practitioners and Dentists Union, and Dr. Alfred Karago from the National Cancer Institute,
who are with us here in the studio, and we welcome your contributions here on the broadcast. Towards the tail end of this show, we'll be sampling your feedback on Twitter. The hashtag is Daybreak. The SMS code is 22422. At Citizen TV Kenya, at Ayub Abdikadir, and at Safin_Achieng. Dr. Bhimji, may I come to you now? The President has committed to the people of Kenya, of course, that we'll have a universal health insurance that will enable every Kenyan to seek treatment in hospital or hospitals and walk away without paying any penny. That is a pledge he made. Now he has been given the mandate, of course, as the Commander-in-Chief. But when you look at the very glaring gaps that we have talked about in terms of under-resourced human resource that often flocks out of the country because of employment opportunities or better employment opportunities, how key is it to have a primary healthcare model, as mentioned by the Member of Parliament representing Chika-Igama-Ng'ombe, as to the community health workers, clinicians at the bottom end of the healthcare model to detect cases at an early stage, for example, of cancer and other diseases as well? And will it significantly address the problem that is facing the healthcare system in Kenya?
Thank you, Abdikadir. I think the best place to actually have the bottom-up approach of the government, where actually can actually give better successes, is in healthcare. And that is what we talk about, the functional primary healthcare, that is preventive and promotive, cascading up. And that's why in our country, we have hospitals like level 1, dispensaries, level 2, level 3, level 4, level 5, up to level 6, which are now referrals. And therefore, there's actual need to have these primary healthcare functional. And what will make it functional? This will come when there's actually awareness that the families understand the healthcare system. They understand that they need to actually prevent some of the conditions. They need the particular nutrition they need to eat. They need to have all the mechanisms. And that's where the community healthcare workers, who used to be called volunteers and we think should be called workers, come in, because they actually give families knowledge and advice on why they need to seek healthcare within those particular levels. Then, with that, we're going to see what we call the UHC being arrived at. But as where we are, we see that not happening, because there are no healthcare workers from the grassroots level to the top level of facilities. And the last, I think yesterday we saw the President saying that the teachers, 30,000 teachers have been employed, and therefore the students can go and learn with the parents. But the same has not been said of healthcare. And this is clearly seen based on the trends that we have seen in the county governments. In the report of 2021-2022 in the counties, the county government from the COG have only employed about 700 healthcare workers. That is from the community level to the doctors. That means there was actually, we could say, scarce. There's no employment that took place in that.
That's for the 47 counties.
The 47 counties, yes. So you see, that's one thing that is actually very glaringly seen. So and there's no hope that the counties, as it is now, are going to employ any healthcare workers or any doctors or any nurses, any clinical officers. And the reason is because when you look at the control of budgets, every county has a cap up to 37.5% for remunerations of workers. But about 45 of these counties have exited this, apart from Wajir and Kwale. The rest of the counties cannot employ. So a time has come that we have to look at it, that for we to have a functional healthcare in this country, are we going to have the model of the devolution of healthcare, where we are going to have 48 different governments handling healthcare in a different way, or do we need to have a hybrid structure where we have the hospitals, level 1, 2, 3, to be within the counties, and then the other levels, or the human resource aspect of it, to be centralized? Because what has brought the big difference is that when you look at the security, when you look at education, which have their human resource still centralized, there's annual employment.
Okay.
When you look at healthcare, which is a social service, which is decentralized now, there's no employment. So this lack of personnel, as much as the structures, the services cannot be provided.
All right.
Okay.
And that is a good point to pick up from Mheshimiwa. The budgetary allocation in the health sector now stands at 146.8 billion shillings. This is actually 6% of the country's GDP. And you had the Secretary earlier there saying that this is actually below what the Abuja Declaration states, which should be about 15% thereabout. I mean, are we discussing funding the healthcare, and are we doing it in the right way from where you sit?
I would wish to be of a different thinking and a different approach to the whole matter, because there's no country that will have enough money for what it wants to do. Even as a person, you can never have enough money for what you want to do. It's just a matter of priorities. If we say a county has been allocated 35% of its money to go to remuneration, it depends with remuneration, whom did you employ? When we say they have exhausted the 35%, it means people have been employed. So whom did you employ? You did not employ health workers. We employed village managers, we employed administrators, we employed 1,000 drivers. So it's a matter of priority. Whom did you employ? So you employed and you got to the ceiling of that 5%. So whom did you employ? So health workers was not a priority in the employment. So it's a matter of priority. And when we look at this primary health care, one time when I was in last parliament, we traveled to Cuba. And when we went to Cuba, I was so ashamed of what we were coming to see. Because I didn't see a big building in Cuba. I didn't see a big house as a hospital. The kind of primary health care that is in Cuba, if we bring it in Kenya today, I think we'll diagnose cancers at a very early stage. For example, let me take my constituency today. I have 17 locations. If I treat these 17 locations as villages, every location has a village. So every location, I give it a well-trained clinician. I give it allowed 3 nurses. I give that location allowed 10 community health workers. And these ones retain a file of the families in that village, that they visit every family, home to home. They don't have any other work. They don't work in hospital. These ones don't work in the hospital. Their work is home visit. How much would it cost a county government to employ 17 clinicians times 3 nurses per village, times community health workers, and then you sort out this issue of early detection of diseases and everything. So it's a matter of priority and how we organize our primary health care. So as we discuss primary health care, we are discussing primary health care today where we are in meetings telling people, please go to the hospital. Can we get to a point where we don't tell people, please go to the hospital, where people are seen even at home? We get to that level of organizing our health care. And finally, when we talk about the Abuja Declaration and the financing and employment of doctors and health workers in this country, it's the right time that we realized that we might do so much as a government. Maybe you're a county governor and you don't find it important to employ health workers. And you build houses, you do loans, you do water. Finally, all this becomes useless when you have a 6th generation. So it's better if you sorted health and add a healthy population than having loans and very beautiful houses with a very sick population. So I think the mentality of our Kenyan health system should come from buildings, should come from very sophisticated equipment, because that's what we think. Even in the MES system, the medical equipment, we bought very good equipment, but we don't have trained people to use those equipment. They are lumped in hospitals. I remember, like in my county, we have had a CT scan that have not worked for the last 6 months because of a socket. There's a problem in the socket, and it can only be repaired by the person who was given that contract. So had we spent so much money in the whole scheme, so it was just a cash cow for money. So until we remove our mentality from making money from the other sector, because the mentality that is there now is a making money mentality, where you get you get allocation from the national government, you get money for health, but instead of employing clinicians, instead of employing nurses, you have very big houses across the county.
All right. And Dr. Karagu, let's talk about that population that he has talked about, that we cannot be doing all this, yet there is a sick population. In the numbers that are captured in the report, 46% of the cancer cases actually detected among patients after they have spread at stage 4. What is the diagnosis to why this is happening? Why are we having a very minimal early detection of cancer? Because we all agree that that's the good point to start in managing cancer, but it's not happening. Why so?
I would look at it from two perspectives. One, there is an individual perspective. There is the proactivity or the decision by individual people to actually go out for screening. When you look at the data that's been collected over time, in this country, we have not done very well as individuals or as Kenyans in terms of going out when you're not sick. I think, and that's part of I agree with what Mheshimiwa is saying, that we need to actually focus more on primary health care with a view to adopting a wellness model, whereby we are more concerned about understanding our state of wellness rather than just going to be treated when you are sick. So when I say the individual factors,
when you are very sick,
very sick, exactly. Because
the verb intensified.
Yes, I think essentially, in fact, in the health sector, we say that, particularly for men, the two things that will make men go to hospital is one, pain, two, blood. When they don't see pain or blood, they will not go to the hospital. But now the unfortunate situation is that most of the cancers we're talking about, by the time they are presenting with symptoms, they're already advanced. So the number one element that how to address that glaring gap is to focus more on awareness creation, maybe using our community structure, using even our survivors, because part of the reason why we had the National Cancer Summit is to even to build a pool of advocates who can create that kind of awareness that I have gone through this experience. I was probably screened, detected early, and I've been treated, and I've been able to get to where I am. But then the other perspective is the health system perspective. We have also realized that there's a good proportion of Kenyans who will go to the hospital or to the healthcare system on repeated number of times before they are diagnosed with cancer. That then is an indictment on our ability as a healthcare system to correctly and identify cancer cases early enough. You will find that the patients will be treated for amoebiasis, they'll be treated for ulcers, and yet this person either had a stomach cancer developing or a colon cancer developing that was not picked up. So that also is an indictment on us to think about how do we strengthen the capacity within our healthcare workers, particularly in those lower, because the majority of Kenyans will go to a dispensary or a healthcare or a health center. So how do we ensure that the nurse at the health center, the clinical officer at the health center, has that high index of suspicion, so that we don't have patients being seen for the fourth time, for the fifth time, being treated for something that is actually not what they have. So I would say that why we're having that is a high proportion of people don't go out when they are not feeling sick to be screened, and yet these services are available. But then there's also a component of strengthening our healthcare workers, with knowledge, with skill, so that by the time some of these patients are coming, they don't end up coming so many times before they're detected.
Okay.
Yes.
Dr. Bimji, we talked about the shortage in terms of doctors, the lack of pay, you said, across the counties, the failure in the absorption of the doctors or the professionals by the counties. However, even as we talk about the health sector allocation, 146.8 billion, 6% of the GDP, 9% to fill that gap. And talking about the quality of life as enshrined in Kenya's Vision 2030 and Kenya's health policy 2012 to 2030, we are now about 8 years before we actualize, 7 years before we actualize that, in transforming Kenya into a global healthcare hub. I mean, how then certain are we that these achievements will be met with the current state of affairs? To
answer you, I'll just first go with what Dr. Kiragu was saying. when we talk about the primary health care in the country, we focus only on on not having the doctors in the series. But one thing that has come out that makes many of these patients to be undiagnosed or to be not identified in time is because you realize you can have a small sub-county with no doctor at all. There's some of the sub-county is almost level of a district. So without that, or without incorporating doctors as part of the primary health care, within the community health care, within the clinical officers are there, with the nurses, then it would be very difficult to actually identify most of these cases. And they have to be referred to level 6 before they're identified. So that's actual need that is there. To answer you, I'll say that this actual need for us to see the model of healthcare that will work, we have to change the mentality of healthcare being a recurrent expenditure as a country and look at healthcare as an investment and a backbone for economy. But we have not looked into that. We look at healthcare as a recurrent expenditure, then the cost of the drugs, the cost of employing workers, the cost of employing doctors, nurses, and that makes the budget to be limited. In the whole of Africa, as of now, we have Rwanda and South Africa that have reached over 50% of the budget declaration. And you can see in the number of doctors, the number of healthcare workers they have in their country. For example, in South Africa, there was only 400 doctors that were not employed in the year 2022. A one-day march led to that employment within 2 weeks. Mm-hmm. So they have a workforce of healthcare workers with about 15,000 or about 16,000 doctors in public sector. But here we have about only 3,000, 4,000. So it's very difficult to equate the healthcare delivery in these two places. So there has to be an intentional plan to have human resource to run the healthcare.
Okay, but Dr. Bimja, I wonder how intentional then the government is, because you talk about the protest in the Rainbow Nation, South Africa, which prompted the government to absorb in the doctors. 400, you said. Here we're talking about 4,352. There was the longest doctors' strike ever in history of nearly 100 days that paralyzed the healthcare system in the country. And then the government's failure or reneging on the memorandum of understanding that you signed with them, the organization that was then led by Dr. Ouma Oluga, and which, of course, you subscribe to. If that failed to prompt the government to absorb you, the professionals, and often a budget of about 3 to 4.5 million to train a doctor, and then the end game is doctors flocking out of the country for greener pastures or others committing suicide because of lack of employment, then what's the point?
If you looked at our notice that we gave to the government on November 28th, it was the intention to proceed on industrial action. And the whole issue was that we were not looking for money or for extra funds for the doctors or for the healthcare workers. Our intention was to have a functional healthcare for the Kenyans. That is it possible to go to the hospital and get the doctor, get the services, get the drugs, and get the laboratory services working. We have what you call an MOU where the COG and the ministry agreed to look into these matters. But even up to that, we have an appointment of healthcare workers, 514 healthcare workers, that advertisement was done. The appointment that was given to them December 2021. To date, they have not been employed. So that gives you the clarity that there has to be an action. And the action has to be deliberate by both the national government and the county governments, or else there's much deliberate effort to make healthcare not to work so that the private healthcare can actually succeed. Mm-hmm. That also must be there, because you look into it that who then runs the private healthcare in the country? Who are the investors? Are they the same leaders who are in the cabinet? Are they the same ones who are in the parliament? Okay. Are they making policies that will ensure that we have excess of healthcare workers or doctors, not in the facilities, but outside, so that we can have a lower cost of employing them from the private sector? Those are things that we need to look into. And that's why, as a union, we are saying that if, in case we call for industrial action, to have doctors employed, it is not for the doctors, it's for the Kenyans, okay, so that the healthcare can actually function.
Thank you.
All right.
Yes.
I think
as you add on what he has said, also tell us what has been done to tame the commercialization of health in the country, because that seems to be where the problem is.
I wanted to pick it from there and tell Dr. Ali it's not leaders who run the private health clinics at hospitals, it's them doctors. Politicians don't run private hospitals.
So it's sort of like a blame game.
They are led by,
who runs the health?
They are led by doctors, the same doctors. So what I want to say is this. If you so that's where the complication is. When I sat in the last parliament, I brought a bill in parliament to create a health commission. that all the workers in this country are employed by the national government. And it was shut down by the fact that it was undermining devolution. So I was told all this devolved, you can't continue with this bill. But you see, if we continue with this discussion, we come to the same place again. The union says we give orders to the national government to employ. The governor will say, don't employ doctors for us. It's for us to employ doctors. Employ for your level 6 and 7. So, but when we are dealing on strike issues, we deal with the national government. So the national government will employ doctors and take them where? Yeah. The governors are saying it has to employ our doctors. Give us money, we employ. When they are given the money to employ doctors, for example, let me give you a very good example. Through last parliament, we used to give a conditional grant to all level 5 hospitals. Because we assumed level 5 hospitals are supposed to be referral hospitals for legions. So we give Embu, Tuadil Million, Nyili, Melu, Kisi. We were given conditional grants. But we found out that we gave a conditional grant to a level 5 hospital, but the county government did not put that money in that hospital. It did other things. It did loans. So we withdrew the conditional grant as national government. So now the conditional grant is no longer there. So unless you say we'll give a budget for health, and then we'll link fence it. But if you try that, then you'll be told you are undermining devolution. You are not supposed to guide a county on how to spend their money. So this issue of we are undermining devolution, we are tampering with the structure of government is where we are stuck.
But is it really about undermining devolution, or there could be an underlying?
Yes, I want now to think about that. Yeah. It's not a genuine thing. Yeah. Finally, it's, somebody challenged me, is how we think about health workers in Kenya today. And somebody gave me an example of COVID time, now that Dr. Ali mentioned Luada. During COVID time, Luada took all their doctors, their clinicians, their nurses who are in health schools, their MTCs, their medical schools, and used them to fight COVID. But in Kenya, when COVID broke down, we closed all the MTCs, we closed even Nairobi University, we closed all medical training, as we were closing everything. So we told these doctors, these nurses who are in health schools to go home, and when they went home, they found their mother has been trained as a community health worker to teach them how to fight COVID.
Okay.
It's how you look at
well,
it.
Therein lies the very thin line. And Dr. I'll come to you because COVID largely has been a trigger factor. Yes. We have seen the rush with which counties have been setting up healthcare centers, including ICUs at the county centers or the devolved units when the pandemic struck the country. And the first case confirmed in March 2020 by then Health CS Mutahi Kagwe. Here's what we are saying on the Twitter hashtag at Daybreak, at Citizen TV Kenya, at Ayub Abdikadir, and at Safin_Cheng as we continue with the discussion. And this coming up on your screens shortly is from Engineer Lazaro, who says lack of enough skilled manpower to detect cervical and breast cancer at early stages what's killing us. Government should invest adequately in recruiting more qualified doctors in every level 4 hospital in every county.
Bob Otieno Owino, treatment of cancer has become very expensive for Kenyans. Hence, they are reluctant to go for screening to know whether they are affected to be cured at an early stage.
And we have this from Asamo_. The issue of health is not devolution and lack of political will, he says. The functions should have been costed, then funds attached. Again, I don't support the idea of CHV, he says. And the community health volunteers, that is, actually they should be paid. We need a health service commission to streamline health.
All right, and continue sending more feedback for us. We'll be sampling them. We have there Paulo Rodi. You say Kenyans should understand that counties inherited a bloated human resource from municipalities and town councils. We have drivers and messengers earning over 70,000 shillings, and they take loans to staff their pay slips. Counties are grappling with this kind of employees. All right, Paulo, thank you for that.
And this from Gode Barasawere. The contributions that the government collects in health insurance schemes should be sufficient enough to get Kenyans diagnosed and treated from the ravaging cancer ailment at very early stages. It's doable activity, he says.
All right, and we have one more. Reverend Harrison Kosgei, you say one day this spirit of cancer will be defeated in the mighty name of Jesus. Thus let the government invest more on this in collaboration with county governments. God bless. Thank you, Reverend. of course, continue sharing with us your cancer experience and also your opinion on what you think should be done by the government and all of us in addressing the cancer crisis in the country. And we do appreciate your feedback. And just to bring you in, Dr. Karaguon, one of the, our viewers there talking about the cost of treating cancer. I don't know whether in your survey that is also addressed, because if I quote what Dr. Githinji Gitahi from NCI just said about chemotherapy cost in the country, about 37,000 per session. NHIF caters for 22,000, leaving the patient with a burden of 15,000. I mean, how many Kenyans can afford 15,000 after every 2 weeks? That is why one of the viewers there say that the majority of them prefer not to know that they have cancer, because the stress of where you're going to get the money will kill you faster than even the cancer. Talk to us about how this cost issue is being addressed.
Definitely, for the financing for cancer care is something that has been of great concern to us, because it's at the heart of access. For as long as somebody is not able to pay, then that becomes a problem in terms of us even being able to achieve our, treatment rates and so forth. So we have been very deliberate to engage with the NHIF, because ultimately for us to get a sustainable solution that would enhance, universal access to cancer care in this country, that must be wired into the whole conversation of universal social health insurance scheme. Because this country must have a system that enables every Kenyan who is enrolled under the insurance system to be able to access the comprehensive set of services, from screening, diagnosis, all the way to treatment. So I would say that NHIF has played quite a bit of, it has played a role in terms of enhancing access to treatment, but there's still a lot more that needs to be done, because, as you correctly said, the way their packages have been structured previously, you'll find that patients will require probably up to maybe 12 sessions of chemotherapy. NHIF takes in a span of like a year, for example.
Okay.
And the NHIF probably at some point will max out at around the 5th cycle, 6th cycle. So they're left with almost half of the treatment for them to take care of. And that becomes a big challenge. So what we are advocating for, and even in our engagement with the NHIF and all other stakeholders involved in financing, is for us to get a sustainable way of ensuring that, in as much as possible, for the highest proportion of services that a patient will require, they should be covered under the social health insurance. And I'm happy that last week when the CS came to officiate the Cancer Summit, she actually made a commitment that as a ministry, they are very keen on ensuring that NHIF is actually converted into the social health insurance scheme by July this year. So that's where we want to see ourselves, that Kenyans are not, financing does not become a barrier.
But when you say social insurance scheme,
yes.
What does this mean? Apart from changing the name, talk to us about how the structure is going to change and how it's going to take care of the vulnerabilities of that common Kenyan who is struggling to meet the cost of healthcare.
I think the whole concept of a social health insurance scheme is to expand the pool of funds available to pay for healthcare. So that means that as many as possible, as many Kenyans as possible are contributing to that pool of financing. The idea is for many of us probably who are healthy, don't end up eating into that pool. So that now that pool then becomes available for those who are in need of care. So that's the whole concept of the social health insurance scheme, that it's number one, it takes care of almost the entire population. Number two, it also expands the range of services that are available through insurance, so that instead of having just treatment services available, now you expand the pool of services that are catered for by insurance, including diagnostic, screen. So that's the whole concept.
So it's going to be a comprehensive.
Yes.
So that, as you have mentioned, NHIF at some point over the year pulls out after the 5th or the 6th cycle of the chemotherapy treatment. So these will cater, say, for example, of the 12th, for the entire period of the treatment of the cancer, for example.
That's the intention, that for those who actually require treatment, they get taken through the entire process of their treatment. So that would mean that, for example, in these 12 cycles, they're able to...
But I know all of you have... But how will this work in a population where, Dr. Bimji, you said earlier, is it 70% of Kenyans that are not,
80%.
Yeah, they are not under NHIF?
No any insurance.
Insurance.
Any insurance?
Public.
Yeah. So how is this going to make it practical for me, from your perspective?
No, me, I will just say that universal health care, as currently envisioned, is a political dream. It is a mirage that may not be achieved. It may be a political vehicle for some time, unless we get to realize that we need to have functional public health care to actually see it. Because the cost of health care is rising every single day, and this comes in when there's increased privatization of health care. So as long as we're going to have the social services that we have as a country are getting a bigger chunk of it being privatized, then we can't see that universal health care. We have just recently seen that the government need to have a policy whereby the leaders, political leaders, and the governors, and the civil servant, and the workers actually appreciate and get services in the public health care. You trust, as a governor, that I am the one in charge of health care in my county, and I can walk to level 5 in my county and get the services. But if we all, the leaders in the counties and in the country are seeking health care in the private, how then are we going to make sure that these particular public facilities work? If we, as a government, take more than 20 billions for our civil servants like police to private insurances, then how are we going to make the NHIF that we want to entrust with the population to work? Or is it poor medicine for the poor people and better medicine for those who can actually afford? That's why there must be a deliberate effort by the government to see that the public health care actually works from the grassroots levels to the level 6, that the levels of hospitals, as they are graded, as the level 6, level 5, level 4, and level 3s, offer the services as it is.
Okay.
Because with that, then even the political leaders, with their families, they're able to get this, to have confidence to get services in those facilities. But if you are, as a leader, has no confidence in the public sector and only the facilities, then there's no way we can say that there's any universal health care that we will access in the near future.
Yes, Honorable Patrick Munene.
So I wanted to come in there. One, I want to say, as we discuss the future of cancer, we are discussing the future, how we'll prevent, how we'll screen. We need to realize that there are people who are sick with cancer right now.
Yes.
And the biggest question is these people are discussing future. I'm sick, I'm at home now, I don't have money for chemo. So what will happen to me as they discuss what they will do in future? So I think the suggestion of having a cancer fund first comes first. As we started doing our budget now, we need to put a cancer fund. Secondly, we can't say NHIF is unable to cater for treatment. I think NHIF itself is a scam. And I will say this with a lot of confidence, that there have been a lot of stealing in NHIF. The last report I looked at for NHIF, their own report, they said that they are losing 10 billion per year in siphonage, whereby we have people sitting down in a private hospital in a room, and they prepare files, they admit you, they give you medicine, they discharge you, and they are paid by NHIF. So NHIF is losing a lot of money through siphonage. So first we'll have to deal with the cartels in NHIF. And finally, as a government, and I want to challenge Parliament, I want to challenge the leadership. Because me, when I talk about cancer, I don't talk about cancer as a Kenya Kwanza or as Azimio, and people shouldn't forgive me for that. I discuss cancer as a victim. So when we say NHIF doesn't money, who provides insurance for the police in this country? It's a lot of money. It's a multi-billion scheme. It's a private company. Who provides insurance for the forces in this country? It's a private company. Who provides all the insurance for Parliament in this country? It's a private company. If we took all this money because it's coming from the same government, and put it into NHIF, which is government-owned, how do you don't trust NHIF, which you are telling us you want to build, and then you take your money and give it to Blitam to take care of teachers. You take another one, you give it to another company to take care of doctors, the same doctors in a private company, and then you tell us you have confidence on NHIF.
Yes.
We need to take all this money, take it to NHIF and make NHIF pull it together and make NHIF one strong body that takes care of Kenyans.
Okay, Honorable Munene, okay. You underscore the need for a policy shift and address the structural problems within the NHIF, citing the cases of corruption and the malfeasance in terms of the leakage of the resources. But then I wonder, because I'm quoting the President, he said, and I quote him, this was in June when he launched his manifesto, "We have committed to the people of Kenya that we will have a universal health insurance that will enable every Kenyan to seek treatment in hospital and walk away without paying any penny." And you all agree there needs to be a pool where all these resources are then sourced out from.
Yeah, that's where I'm coming in.
Then where is the line? There seems to be a goodwill from the government, this coming from the president, now that he has the mandate. I wonder how this is going to be actualized then, because we have talked about the problem, then the practical bit of it. How is it going to be actualized?
That's where I'm coming in. I don't want to discuss President Ruto as if he has been president for the last 10 years. He's starting his presidency. So I'm saying as he starts his presidency, to fulfill his promise of making NHIF cater for every patient in this country. I'm telling the president, there is money here already. It's in the government. The government is giving insurance to public servants. The government is covering parliamentarians with a lot of money. The government is covering teachers. The government is covering the police. Those are multi-billion insurance schemes. Why not stop giving government money to private insurance schemes and bring to the government insurance scheme, which is NHIF, and we'll have a pool that will take care of all Kenyans? Why are we looking for money outside?
What you preach?
Yeah, actually, I completely agree with what Mheshimiwa is saying, that the whole idea about the social health insurance scheme is to ensure that, the consolidation of the various, because when you look at it right now, NHIF actually has bits and pieces of, the Linda Mama here, there is something for, secondary school students, there's what is going to civil servants. So when all this is pulled together, it comes back to that whole concept of insurance. Insurance is the wealth, the well-off offset the poor off, the healthy offset the sick. So that at any one point, you will not have the whole population sick. So the whatever had been assigned to maybe the medical scheme for MPs, probably half of that money is never utilized. But it should be in the pool where there is greater need in the bigger population. So if that is made to work, I sit in a space where I have been in the cancer control landscape for the last five or so years, and I have seen what a properly functioning NHIF has potential of doing.
Okay.
5 years ago, the problems of accessing cancer care were much bigger than they are right now. And because NHIF has come in, even with its own challenges, there has been progression. So if we are able to consolidate all this funding, including what Mheshimiwa said, I think in the manifesto there was something about a cancer fund, a chronic disease fund.
Yes.
So all these things to be put together so that whatever maybe the social insurance scheme is not able to take care of, then some of these funds can come in. So it's just that policy shift of ensuring that we pool our finances together. Yes.
Dr. Bimji, the vision of the head of state is that every Kenyan seeking treatment will walk in hospital and get out without spending a penny. Zero. How practical is this, and what will be the cost implication? Who is going to bear this burden of cost? Let's make it practical.
When I look at the manifesto of the president, there was a plan to employ healthcare workers. And there was a plan to have a reformation at KEMSA to ensure that there are drugs in the facilities. There was a plan to have hospitals actually functional. So it's actually a vision that is achievable. And the only way that can be done if there's investments in healthcare, if we actually put funds in healthcare. Currently, when you look at, for example, the employment, and if I just become a bit more specific of doctors in this country, as per what you've seen, we have about employment of 200 doctors in the whole country per year. That means in the last 5 years, we've had only 1,000 employed, while we are producing about 900 per year. Mm-hmm. When you look at our hospitals, from the case of Master Travis from Thika Level, from Kiambu, the cases of Mama Lucy, the cases of, in this country, if somebody gets any emergency services, you're almost sure that you're going to die even if you go to the hospital, because you will go to the hospital and not get the doctors there. And this is because they have not been employed. And we have, on the other side, a bewilderment of frustrations on these doctors who have graduated. Out of those 80% who are actually graduated, we have seen cases where a doctor walks to Kenyatta hospitals and start offering free services at the accident emergency. What then ended up is that this doctor was arrested to Kenyatta police station. We have seen cases whereby doctors going to private hospitals to offer free services. So there's actually need that the unemployed doctors in this country, who probably most of them will try to move out of the country, maybe 30%, and those who remain after all this training really wants to help the Kenyans and the government. So for the manifesto of the president and for us to see healthcare actually functional, we have to strongly focus on the human resource. And how are we going to do this? We have seen the complaint and also frustration from the county governments when they're saying they don't have funds and they've reached the budget ceiling, the controller of budgets really cautioning them on this. This is the time that we need to shelf egos from the governors and from every angle and see that there's need to create health service commission. And what will this thing do? This will unburden the counties about over 20% or 30% of their budgets that are going to healthcare, because they'll be still having the allocation that they need to have. But then we'll have a centralized human resource where there can be annual recruitment of these healthcare workers and being sent to counties as per the demands. So that is one thing that a high time has come where we need to look at it. Okay. And in the manifesto also, there was a promise that, because we had brought this at the point of the Health Economic Forum during the campaigns, and there was a promise that there will be discussions between the healthcare workers and the counties to see that there's need to build this health service commission, which will ensure there's more training, there's more employment, there's more promotion, there was more motivation. Because as we speak now, we have seen many industrial actions in the counties, and we're still going to see them because, as you know, healthcare workers are very honest workers in the counties. But when they go for 2 months, 3 months without their salaries being paid, like in Taita Taveta, or like in Nyamira County, where 3 months down the line they will paid salaries, you realize that they will be out of work. And the ramification of this is to the wananchi. The
burden will be on the people. Honorable Patrick Munene, then from the policy perspective, because the control of budget, in a report that it presented during the Intergovernmental Budget and Economic Council, which happened at the Kenya School of Government, cited nearly 100 billion Kenya shillings in eligible pending bills. These are bills where there are no evidence of paperwork for the work done, yet there are considerations for payment. Of course, some percentage of it has been paid. I wonder the vision of the leaders across the counties in not paying adequate attention to the health workers. And why do you think so, from your earlier statement that they are not prioritizing healthcare as an important aspect?
I'll go back to what I said again. I'm the member of parliament who brought the Health Service Commission bill to parliament. And I still believe up to today that the Health Service Commission will sort out the issue of human resource, will sort out the issue of human resource in the health sector in this country. Let me give you an example of security. Security officers, the police, are employed by the national government. The county commissioners are employed by the national government. But that doesn't mean that the county government or the governors or the members of parliament don't tell them what to do. So even if doctors and health workers are employed by national government, they will still be under the jurisdiction of the county government. And that will even sort out sharing of health professionals. Because as I was discussing with Dr. Ali, even this issue you are talking of oncologists will not have enough money at any particular time for every county to have their own enough doctors. But under the Health Service Commission, a doctor in Tharaka Nithi can go treat people in Embu, can be transferred to Nyeri because it can be shared, because he is at a national commission. So I think that will be an easier thing for and the president. What I know about the president is that when he sets to do something, and he has already shown that what he promised is delivering, because he promised to sort out the health task force issue, he promised the Health Service Commission. I think it's the right time now we in Parliament started working on that thing. Problem comes in when we told that having the commission requires a referendum, because it touches on the basics of devolution.
there seems to be a back and forth over who should be in charge of the health sector, between the national and the devolved units. And this seems to be affecting even the human resource, at the devolved units. I don't know how best, you think this can be addressed.
I think governors have had no problem with buying medicine. Governors have no issue with the construction of hospitals. Their biggest problem is employment. As Dr. Ali said, we have this culture of looking at investment in health as an expenditure, as a one-way expenditure. We have never understood that if you employ a doctor, they have a healthy population, then it becomes an investment for you. So the issue of taking health allocations as an investment is a problem in this country. So I believe because governors are good at building buildings, they are good at buying procurement. They love the procurement bit. So can we leave them with that? And then the national government takes care of the task force, the workforce, the human resource bit.
Okay. Dr. Karagu, coming to you. How then key is the centralization of a health service commission? Because this is also what the medical professionals have decried for a very long time, saying this will look into their welfare. And I'm posing that question in view of the fact that we are at the moment below par in terms of the recommended World Health Organization, WHO, doctor to patients ratio, which is supposed to be 1 to 1,000, but we are at the moment 1 to 17,000, one doctor to 17,000 patients. This seems to be more than 16,000 below the recommended, that is according to the World Health Organization recommendation.
Yeah, the issue of centralization of human workforce would be very important, particularly when you think about how to address, an emerging issue like, the cancer burden in this country. We realize that the specialized workforce in this country is, is not adequate. And that then brings in the concept of resource sharing. Which is also aligned even in terms of what you're trying to push across in terms of the policy shift in creating capacity for effective cancer care in this country. For this country, we think that we need to have a model whereby you have sort of regional centers, of excellence that are providing care across the country. So when you have and that's one challenge that we are faced with this, with pushing the issue of regional centers is the current model of having workforce, domicile at the county, then brings up the issue that Mheshimiwa was bringing about. Like if you are an oncologist in Tharaka Nithi County, for instance, because of the current model that we have, they would have challenges, providing their services outside the county that employs them, because the county will insist that we pay you, you provide services within our borders. So I see a clear benefit in terms of centralization, because you'll be able to, to share some of this scarce resource. We are expanding, access to things like radiotherapy. And for radiotherapy, you need to have some very specialized, officers. You are radiation oncologist, you are physicist. In this country, for instance, we have about 15, between 10 and 15 medical physicists who are required to, who are critical components of provision of radiotherapy. So I see such, highly specialized scarce resource being best utilized through a resource sharing model that would be effected through centralization.
Okay.
And I think that also would, even from where we sit, that also helps in terms of enforcing standards, ensuring that in terms of standardizing care across the country, then it's much easier as opposed to having workforce spread out all across the country. Yes.
Dr. Bimji, talking about standardization of care, I wonder when ours will be a healthcare model that is people-centered, that places people at the epicenter. We talked about community health workers. There was a tweet from one of our viewers that they ought not to be voluntary health workers, and that they should be paid because of the role that they play at the bottom end of the pyramid. But when will time be ripe enough for an engagement by policymakers in terms of a change which will facilitate meaningful community engagement in our healthcare system?
We all hail from community. We all come from community. And when we talk about community, it's where we all belong. And that's why I was saying that even if we look at how governors have been putting the issue of healthcare and the ministry, we have to come up to a point that we get to know what is good for the Kenyans. It is the Kenyans who need to make decisions on the issue of healthcare. And one thing that the Office of the Attorney General brought out clearing, that the fact that healthcare is devolved does not mean that the human resource component should be employed from the county government. And when this has failed over 10 years, we should not continue with the same thing and saying that it's against the devolution. We need to actually bring a change to it. But regarding community health volunteers, as a union and as workers, there's nothing like you are at the base of offering services, because you are ensuring that every community, every household have access to health care, and then you are considered a volunteer. It's work. And therefore, that's why we are saying there's need to actually see community health care as workers, but not volunteers, because then there will be commitment of time. There's a commitment of effort, and therefore that really brings dignity to the services that they're offering. And as a union, we actually worked on a memoranda with them to ensure that even we petitioned the parliament to make this in the act to actually see that the community healthcare workers are actually respected and dignified as workers. Because with that, we will have more commitment and more access. But just to sum up, healthcare is enshrined in the Constitution as a right. And the Constitution also brings up the aspect of quality. We have seen that because of the devolution and because of the different interests that exist, there's no quality access for everybody, regardless of the ability to afford. And therefore, that's why we need to come up and see if this has failed, why don't we then have a centralized body which will ensure that the 4,000 doctors that are not employed, the 10,000 clinical officers, the big number of nurses, all these people that are not employed who are critical, because it is unethical to have a doctor outside, unemployed, outside the hospital, and go to the hospital and lack those services. And as a country, we're actually doing badly on that. So why can't we then have a model and ensure that all these doctors are employed, so that actually, by employing these 4,000 doctors, we'll need 25,000 more to reach the normal ratio of the WHO. So why can't we as a country prioritize the need to have doctors, the need to have nurses, the need to have a functional healthcare?
All right. We need to have a functional healthcare. But as it currently stands, Daktari, do we have the capacity to manage the crisis? Let's go back to where we started. We're almost winding up. The cancer crisis. Numbers tell us that 75 people die every day. 42,000 cases annually, new cases diagnosed annually. Out of this, almost half, in fact, more than half, succumb to cancer, which is very unfortunate. So do we say that we are at a place where we can manage cancer? We see a lot of medical tourism. Is it just perception that other countries can offer better services, or we actually cannot handle cancer? Where do we fall in those two extremes?
I think I would want to, authoritatively state that as a country, we have the capacity to manage cancer in this country. Over the past few years, there has been a progressive building of capacity. And I dare say a progressive building of capacity in the public sector, because traditionally, the biggest challenge we've had, even in terms of the high cost of care, is because most of these services were available in the private sector. Now, we have managed to expand access to, cancer care services, not just within the national setup, because when you look at our national referral hospitals, Kenyatta National Hospital, Moi Teaching and Referral, now Kenyatta University Teaching and Referral Hospital, which is actually now has been positioned to be a center of excellence in terms of provision of oncology care. Over the past 1.5 years, we actually seen a shift of patients moving even from the private sector to go to Kenyatta University Teaching and Referral Hospital. So I feel very confident that we have the capacity, because now that capacity has cascaded from the national level to the regional levels. Only a few days ago, our cabinet secretary was in Garissa to officially commission
the regional
center in Garissa. Previously, the Mombasa one was commissioned, the Nakuru one was commissioned. In terms of spread across the country, we have about 10 of our county referral hospitals able to provide at least 2 or more modalities of treatment. When we're talking about chemotherapy, we're talking about surgical treatment. So when you go to facilities like, Nyeri, you go to Meru, you go to your likes of Machakos, Kisumu, Kakamega. So there has been a deliberate shift to strengthen capacity across the public sector. And that is going to, number one, increase geographical access to cancer care, but also address the critical issue of financing, because the advantage of accessing care in the public sector is it is subsidized through government funding and through taxation. So what I say is, have we done enough? We have not done enough. We still need to do more, because there are a number of there is still more need to spread out the services, and particularly to build greater capacity among our health workforce, so that we have, when you have these regional centers that we are coming up with, we ensure that we have the requisite workforce that needs to be there. I'm also worried about, and that's where the issues of devolution come in, part of the challenge that we face is even issues of supplies. So you have this clinic set up in these regional centers, but then the issues of supply of drugs then become a problem. So we must address all this holistically, so that we just don't begin services, but ensure that we have services running and the systems to ensure that these services are actually providing the right care are available.
Honorable Munene, then as we talk about the framing of our healthcare system, the primary level, to have a preventive and promotive healthcare system, talking about the welfare of the healthcare workers in the country, the need for the centralization under a human resource that the national government, as per the proposal you heard, ought to be undertaken. On top of this then, and as a supplement, how do we leverage on technology and data-driven healthcare system to spur that growth that we need towards the vision that we had?
Okay, thank you. On that, I wish to say this. I've looked at a good example of Kenyatta University Teaching and Referral Hospital, which was operationalized around 3 years ago. If you go to them right now, their biggest problem is the queue of cancer patients they have to deal with. They are unable to deal with the queue of cancer patients they have. So we need to sort out the quick gains first before we discuss the future. One, I think NHIF, as it is today, if pushed, should be able to cater for cancer treatment. I still believe that, because if them themselves tell you we are losing 10 billion per year through preferage, 10 billion is enough if they are treating half of the sessions while losing 10 billion. What if we cross this preferage? It means they can be able to cater for cancer patients. So I believe the regional cancer centers is a way to go. On the issue of ICT, if we will never have enough doctors across the country. That's something we need to agree. As we employ doctors, we'll never have enough. So the issue of ICT still remains very important, that doctors can still consult their patients from where they are. And finally, I believe we need to be genuine with each other. This issue of employing health workers, saying it's disrupting devolution, it's a lie. Because when the president proposed to employ community health workers, nobody went against it, including the governors. They said it's okay, the president can start paying community health workers. So the president can pay health workers, but should not pay doctors.
So there's double.
So let's be genuine and sort out this mess.
All right. We're just about to wrap up, but not before we take sample a few of the messages we are receiving from our viewers across the country.
That's on Twitter.
On Twitter there, at Sawe, you say government and elected leaders play a crucial role in this effort. It's time to prioritize the health of our citizens and work together to provide the best possible healthcare facilities. A healthy nation is a strong nation. Let's make it a priority.
Here's what Remy Bute says: counties face major challenges in the 4 key components of cancer control: cancer prevention, early detection, diagnosis and treatment, and palliation. We need to close the cancer care gap. People who seek cancer care hit barriers at every turn.
All right. And Okello Mwalimu, you say current regime must do everything it can to make UHC a reality. CS Health should be reminded that NHIF can be made effective without interfering with its acronym. For instance, the process of seeking treatment should be made simple and more ailments should be covered.
And the last one from N. Jenga, he says, Honorable Patrick Munene has a great insight on investments in health and what it means to invest in healthcare workers. The panel is on point on the issues that ail our healthcare system.
All right, and this is the point we thank our panel for creating time for us this morning. Maybe a round of your final remarks as we close this conversation. Mheshimiwa, let's start with you.
I would wish to tell Kenyans this. Being the Vice Chairman of the Health Committee in the National Assembly under the leadership of the government of Kenya Kwanza under William Ruto, will push so hard to make sure that health is made a priority in this country. And will push too hard to make sure that every Kenyan, regardless of their social status and economic status, will be able to access quality health care.
All right, Dr. Karagu.
Mine is to, as the CEO of the National Cancer Institute, a state agency in the Ministry of Health, and on behalf of my minister and the entire health sector, I would want to assure Kenyans that we are well seized of the challenge that is of cancer in this country, and we are ready to work very collaboratively with all our stakeholders, because we all have a role in terms of addressing this emerging burden. And we started off the convention last week, and we are convinced that if we put our efforts together, we shall be able to rise above the cancer burden. So we call upon all Kenyans to take up our role, and we will work with them to ensure that we address cancer in this country. Thank you.
All right, Dr. Bimji.
Yeah, thank you. I think I will just tell our viewers that our health is our wealth, and the only thing that we can ensure that it functions is that if we can actually go to the facilities and instead of just being frustrated, get the healthcare that we need. But I believe that with progressive leaders like Honorable Patrick and the government, if they put their interest to the people from the bottom-up approach that was given, then we'll have all these unemployed doctors employed. We'll have people going to the hospital and getting the doctors, getting the services, getting the drugs, and getting all things that are needed. And therefore, it's up to the Kenyans and the citizens to actually make a call and actually talk when this thing is not attainable, because we are the ones who are in charge of the government, we are the ones who voted, and therefore we are the ones who actually can put the government, both the county and the national, accountable to ensure that, as enshrined in the Constitution, we have a right to access to the health care.
All right, thank you so much, gentlemen, for creating time for us as we wrap up. If there is something that COVID taught us, is that it comes at a time when you can be left alone. Countries were left alone. They became innovative. Counties were left alone. Every county became innovative. Families were left alone. Every family became innovative in managing COVID. This is the time for you as a family to think about your health and your wellness. What can you do to prevent cancer on an individual level, at a family level, and also on early detection? The rest, you can leave it to the rest. But what can you do is what you can control.
And of course, that's why we are here. It's the very same people, our viewers who are watching us, and have accorded the mandate to a group of people to govern over us and who have the mandate to better our healthcare systems. And when COVID struck, as you have mentioned, even including other countries with a elaborate healthcare system, the stretch and the inundating of their capacities was at an imaginable level. You have seen what happened in Italy, in the UK, and in France when COVID hit the European continent and also the United States of America, which was among the countries that had bared the biggest brunt of the pandemic. Many thanks for making time here on the broadcast. We appreciate your company, of course, and time. Thanks for your feedback on Twitter. The hashtag has been Daybreak, at Citizen TV Kenya, at Ayub Abdikadir, at Asafin_Achieng. And their company is always cherished as ever.
Yeah. Thank you so much for creating time. Always a pleasure to do this for you each and every Wednesday morning. Daybreak it is. But for now, it's a wrap from us. Willis Raburu is coming up next with the lifestyle segment of the show. Do stand by for that. But enjoy the rest of your viewing from us.
Good morning.